Good morning, my name is Carla McCardle and today we are going to look at wound healing. First of all, we're going to look at acute wound healing and then what happens when this acute process or normal process doesn't happen, and we move on to chronic wound healing. And so wound healing is a very dynamic and complex process. However, it's amazing how often this occurs without complication, given the intricate nature of the process, which we're going to discuss. So we'll look at normal wound healing or acute uncomplicated wound healing, and in particular of post-surgical wounds, and then we look at delayed wound healing and the pathological processes that delay the wound from healing, and we'll touch briefly on management. So wound healing of post-surgical wounds. The desired clinical outcome of post-surgical wounds is to achieve closure and skin integrity with acceptable cosmetic results and minimum complications. So whether a wound is healing by primary intention, which is surgical incision with sutures, or secondary intention with extensive loss of cells and tissue, the healing process is a dynamic one which can be divided into 4 overlapping phases, which we will discuss. The majority of surgical wounds do not result in any major complications and tend to follow the normal wound healing process. And it's important at this point to note that regardless of etiology of wounds, they tend to follow the same. The repair processes are still the same. So what are the 4 phases of normal wound healing? So it's homeostasis, which occurs immediately after injury to the skin. Inflammation then lasts sort of 5 minutes to 3 days. Then the proliferative phase and remodelling, which can take up to 12 months. So what we're going to do now is divide these into 4 separate entities and discuss them. So first of all, when an injury, there's a microvascular injury, there's extravasation, which causes the blood to leak into the site of injury, which then starts the cascade of events of normal wound healing. Initially there is vasoconstriction and blood clotting, and this is vital in starting the coagulation cascade to limit blood loss and provide the site for cell migration. At this point, the platelets also cluster to the injured cell, and these platelets secrete cytokines to attract all of the other cells that are required for wound healing. So this will include your fibroblasts, endothelial cells, and immune cells, and it initiates the next stage of events. Platelet aggregation is very important in order to stop that bleeding and protect our bodies whenever a wound occurs. Now if we move on to the stages of homeostasis. So homeostasis initiates the coagulation cascade, and the coagulation cascade involves 2 pathways, the intrinsic and the extrinsic pathway. The extrinsic pathway happens initially, and this is activated by the molecules that are now present due to exposure of that wound site. This then activates, after a thrombin burst, this then initiates the intrinsic pathway. At the point where the extrinsic pathway activates the intrinsic pathway, both pathways merge together and move into the next stage of healing. What's important within the extrinsic and the intrinsic, and what merges those 2 together, is something that's called tissue factor 10A. And tissue factor 10A is vital in the healing process. It's also known as a prothrombin activator, so it transforms the prothrombin to thrombin, and then thrombin is vital to turn fibrinogen into fibrin, which forms a mesh at the wound site. And this helps the platelets aggregate and form that clot at the wound site. As well as this, thrombin also is very important with the von Willebrand factor. And this comes into play when thrombin activates this to release what we call factor 8, which also participates in blood coagulation. And all of these stages are very important in order to move through the healing process. The main role of that tissue factor that we've discussed is it's very important in terms of the feedback activation roles, and it's released very rapidly, and it causes thousands of molecules of thrombin then to form into the next stage in converting fibrinogen to fibrin. To put this into a diagram, and just to quite simply, you can see the prothrombin activator, which is the tissue factor 10A. It converts prothrombin to thrombin, which then activates fibrinogen to become fibrin, and that fibrin, that as we've discussed, forms that mesh at the wound site. The fibrin strengthens the platelet plug at the wound site. So then at this point, the platelets and surrounding damaged tissue also release pro-inflammatory cytokines and growth factors, so the platelet-derived growth factor, transforming growth factor, and also the chemical alarms required for this stage of inflammation. So as I've said before, they don't happen in isolation but overlap one another. So whenever the platelets and surrounding damaged tissue releases these pro-inflammatory cytokines, they've already moved into that inflammatory stage. So clinically, what's inflammation? We're all familiar with what inflammation looks like. So we have our redness, heat, swelling, pain, and loss of function. But what exactly is going on at a cellular level? So there's a lot of stages involved with inflammation. So that's cell release, chemical mediators from those platelets, where we have our pro-inflammatory cytokines and our growth factors. And this is also known as chemotaxis. This then, and I'll discuss these more as we move through the slides, but this then causes vasodilation and increased capillary permeability. Vasodilation and increased capillary permeability is the vascular response to injury. And what this does, the vasodilation and that increased permeability of the cells, there's activation and migration of leukocytes. Leukocytes are our white blood cells, vital for protecting our bodies against infection. And then obviously phagocytosis, where the bacteria or any foreign body that is at the wound site is engulfed and removed from the body. So the cells release chemical mediators, and these are released into the interstitial fluid, and they affect the blood vessels and nerves. And these are potentially these are what causes those signs that we see at a clinical level. The pro-inflammatory cytokines act as communicators, so they send messages to all of the different cells that are required for the inflammatory stage, and as well as that, the proliferative and remodeling stage. So the important ones are leukocytes, lymphocytes, monocytes, macrophages. I should just point out that some of the chemical alarms that there are things like prostaglandins, histamine, leukotrienes, bradykinin, that are all required for that vasodilation and the different stages of inflammation. Within many of the anti-inflammatory drugs that we see clinically, and the antihistamines, these reduce the effect of the chemical mediators. So those chemical alarms, so if the chemical alarms aren't present within our body, then we can't move on to the next stage of inflammation. The brief vasodilation, vasodilation happens after that vasoconstriction, so that initial response to injury from the nerve reflexes at the injury site. So this then forms that cascade of events in terms of vasodilation. The rapid release of chemical mediators, so histamine and prostaglandins, causes the relaxation of smooth muscle. And if there's a relaxation of smooth muscle, there's vasodilation, more blood can then flow to the area of injury, the blood which has the vital cells needed for the inflammatory stage and indeed for healing. So this increases blood flow in the tissue, which causes redness, that rubor, and then with that you've got heat, so the colour, signs of inflammation. So just to show you in an image diagram, you've got your normal permeability and blood flow on the left of your screen, and then whenever there's increased blood flow and permeability, there's vasodilation. So there's increased blood flow, the permeability is increased, means that cells can now travel out of the blood to the site of injury, and because of that vasodilation, there's more blood to the injury site. So the importance of our increased capillary permeability is that it's increased through the chemical alarms, the chemical mediators, that chemotaxis, and the endothelial lining of the capillaries becomes leaky. So if they become leaky, more cells and more vital sort of macrophages, neutrophils, different sort of white blood cells can enter the site of injury. And this is how we get our exudate formation. And exudate formation is the result of increased permeability, causes local edema, so your tumour, and also it presses on the nerve endings, which then causes that pain and loss of function at the wound site. So activation and migration of leukocytes, and this is the process of diapedesis, where the leukocytes now form on the capillary walls and then move out through the way we said the blood vessels are now leaky. They can move into the site of injury. So the slowing of blood in the bloodstream results from a combination of vasodilation and exudate. So the blood is essentially becoming thickened, and during this cellular response, the leukocytes, the white blood cells, are attracted by chemotaxis to the area of inflammation. And these, as I say, are vital for removing any sort of foreign material, cell debris that's now present at the wound site. So first we have our neutrophils, our PMNs, then later the monocytes and the macrophages, and these all collect along the capillary wall. Once bound to the capillary wall, these cells can then squeeze through the gaps between the adjacent endothelial cells into the interstitial fluid. And this process is, as I've said in the previous slide, is diapedesis and allows the removal of those foreign material. Once cells arrive, the phagocytosis, which is the next stage, is once cells arrive at the site of injury, they can destroy and remove microorganisms, any foreign material, cell debris, so cells that are now no longer needed in the healing process, they can be removed by phagocytosis. At the stage where there's phagocytosis and there's those platelets the macrophages can now activate the fibroblast migration. So the proliferation phase has already started at the end of that inflammatory stage, and fibroblasts, the growth factors released by the fibroblasts attract the fibroblasts to the area. Just going to start that slide again. So at the end of the inflammatory stage, where the macrophages are there and they're involved in the phagocytosis, the macrophages also cause the migration of fibroblasts. So again, we'll go through these slides in detail as we move on, but there's fibroblast migration. The fibroblasts are then needed for the angiogenesis, and so we have a lot more capillaries at the wound bed. Then we have granulation tissue formation, collagen deposition. So when the collagen starts to form that extracellular matrix and the skin integrity is increased, and then our epithelialization. So if we look at fibroblast migration, so this is attracted by our platelet-derived growth factor and transforming growth factor, and these are released by the macrophages. Why do we need the fibroblasts? So the fibroblasts are very important to produce a very hydrated matrix. So if we have a hydrated matrix, then contraction can happen easier. And contractions facilitate wound closure and begin to construct the extracellular matrix, which is vital for the next stage and for collagen synthesis and the closure of the wound in terms of the epithelialization. The collagen synthesis, collagen is synthesized within the nucleus of the fibroblast, and this is required to provide strength and tissue integrity at that wound bed. And they are the foundation, they become the foundation of the extracellular matrix, and this allows the process then to move on to the angiogenesis and epithelialization stages. So angiogenesis is the process of blood vessel formation, and this is concurrent with all the stages, and it contributes to healthy granulation tissue formation, and it also allows more cells to enter that wound site. As collagen accumulates and as the extracellular matrix joins with wound contraction, the blood vessels begin to diminish at that site, so it's no longer needed in the granulation tissue. There's a pink granular appearance of the capillaries whenever there is angiogenesis at the wound site, and due to the nature of a lot of those capillaries and loops of capillaries, the wound bed can bleed very easily and be re-traumatised and potentially re-traumatised. So at this point this can lead into where the wound can become delayed healing or chronic. So epithelialization aims at covering the wound surface with a layer of epithelium, and this is based on the differentiation, proliferation and migration of epidermal keratinocytes. And they migrate from the wound edges to form a delicate cover over the wound area. At this point the integrity of the skin is only about 15% of that of normal skin. The rate of epithelial cover is enhanced if the wound surface does not require debridement and the wound is kept moist, which is where our fibroblasts also come into play in order to keep that wound surface moist and allow for contraction. Further epithelial growth and differentiation re-establish a stratified epithelium and that keratin. The final stage then of normal wound healing is the remodelling stage. Now this overlaps with the development of granulation tissue and continues over a longer period of time. So at this point the remodelling stage can last up to 12 months. So contraction occurs through the interaction of the fibroblasts and the extracellular matrix, which within a primary intention wound, this is helped by the suturing present, but when there is secondary intention, this process can often take longer and more contraction is required within the wound bed. At this point there's matrix metalloproteases, so our MMPs are present, and this is required for the extracellular matrix degradation. So once the extracellular matrix has essentially done its job, then the MMPs are required to remove or to degrade that extracellular matrix. As remodelling continues, MMP activity decreases, and this is what can come into play with our chronic wounds, with being very much the MMPs and the imbalance between the MMPs and tissue inhibitors of MMPs increases. So we need our TAMPs in order to inhibit the activity of the MMPs, so to stop that extracellular matrix from degrading. The macrophages and fibroblasts are reduced by cell death, so our controlled cell death or apoptosis. As remodelling continues, angiogenesis is halted, so those blood vessels that are present on the wound bed, and blood flow reduced as the metabolic activity declines. There's also cellular and avascular scar formation, and again depending on the size of the wound and size post-surgically or a wound caused by a different etiology, scar tissue may be present which doesn't have the same skin integrity as our normal skin. So we'll now move on to what happens when that normal stages of wound healing doesn't happen and the wound becomes chronic. Excuse me, chronic wounds are stalled in the inflammatory phase of healing. There's excessive levels of pro-inflammatory cytokines, there's proteases, including our matrix metalloproteinases, and there's reactive oxygen species, as well as persistent infection that then causes that wound to become chronic. There's also different issues going on in terms of the complications. There's ischemia, potential hypoxia, there's potentially diabetes, there's some reason why the wounds are stuck within that chronic phase, which we will discuss. So as Freiberg in 2015 quite rightly points out, a chronic wound fails to go through that orderly and timely manner. And generally an acute wound has a predictable time frame. However, within a chronic wound, this unfortunately doesn't happen. So we're just going back to the 4 stages and where exactly the chronic wounds, or where exactly there's the delay. So delayed wound healing appears arrested between that inflammatory and proliferative stage. The normal trajectory does not occur in chronic wounds, which appear arrested and fail to progress into the proliferative and remodelling stages. And therefore, because of that, does not heal as normal. So the pathophysiology. So when ischemia is present, what's going on? So the key factor is chronic wound inflammation, and unfortunately, because they appear stuck in that proliferative phase, they are prone to an invasion of microorganisms and ultimately infection, especially where there's hypoxia. And then the microorganisms can invade the area and cause the wound to become infected, which then causes the prolonged stages of inflammation, because there's an influx of neutrophils to try and release or to try and remove the bacteria by phagocytosis. So when ischemia is present, localized hypoxia increases the risk of prolonged infection, and this then this increases the number of neutrophils attracted to the wound, creates further tissue damage, and due to the destructive nature of inflammation, this results in increased MMPs, or matrix metalloproteases, which we discussed within the normal wound healing is required to degrade the extracellular matrix through those timely stages. However, when there's too much MMPs, there's potentially too much degradation, which then causes a cycle of events in terms of more neutrophils, more pro-inflammatory cytokines come into the area and arrest those wounds at the stage of inflammation. There's also hypoxia, and the inflammatory environment increases the reactive oxygen species, and these prevent proliferation by damaging DNA, lipids, proteins, and that extracellular matrix as discussed. So this is sort of a vicious circle of events. So you've got damaged tissue, the increased inflammatory response, so you've an increase in the cytokines, the chemical mediators, which then cause the variant stages of inflammation. This causes an excessive matrix metalloproteases to be present, which then also cause the degradation of the extracellular matrix and growth factors, which then go around that circle again and cause an inflammatory response and the cytokines and back into that process again. And this is how it appears arrested. So infection can also be present within these wounds, as discussed, in prolonged infection. So I'm just going to start this slide again. So what you can see here is the extracellular matrix. They're important for creating the cellular environment required during development. When there's too many MMPs, it causes damaged tissue, as well as the tissue being damaged anyway from the injury due to what has caused the wound or the etiology of the wound. When the tissue is damaged, this causes an increase in the inflammatory cytokines, which causes chemotaxis, which then causes the vasodilation and the cellular permeability, which allows more cells to enter at that wound site. As well as that, there's an excess of MMPs again, which then causes that degradation and damaged tissue. So you can see how this goes through a circle of events. Protease levels, as discussed in the acute wound healing presentation, are tightly regulated, but in chronic wounds, protease levels exceed that of their respective inhibitors. So if you remember the tissue inhibitors of matrix metalloproteases, there's too much MMPs now for the TIMPs to act on. So this leads to destruction of the extracellular matrix, which in turn not only prevents the wound from moving forward, but also attracts more inflammatory cytokines, and thus amplifying the inflammatory stage, or the inflammatory cycle in this case. So the presence of infection can significantly delay wound healing, in particular those white blood cells, those leukocytes that are now entering the wound site and are required to remove the bacteria and the cell debris. So if there's a lot more bacteria in the wound site, there's potentially a lot more neutrophils, and the macrophages then produce more of the platelet-derived, the growth factors, as well as the fibroblasts, and then potentially leading on to those NMPs. So this, if also the patient, so if there's reduced host susceptibility, then there'll be an increased infection. If there's ischemia and hypoxia, there's going to be an increased risk of infection as well. And it's important at a clinical level to know, well, what's deemed to be contaminated, colonised, or critically colonised, or infection. And this is very difficult. This can often be very difficult to detect, especially in those patients with diabetes where it may be infected, but the classic signs of infection aren't there, so that the signs of inflammation that we've discussed are diminished within patients with diabetes. So successful microorganism invasion of host tissues can lead to a variety of infections. Some can be superficial, so it can be a localized infection at that area, and this can potentially lead on to deep tissues, as well as our cellulitis and sepsis. So it's important that we monitor patients that have chronic wounds and potentially get the help needed when there is an infection in the form of antibiotics. It can also lead on to osteomyelitis, which is obviously going to lead or to have the wound appear in that arrested state of inflammation and proliferation. So when a wound is colonised or contaminated, bacteria are present. However, bacteria are in a steady state of replicating, and they can maintain that in the presence of the wound, but this does not delay wound healing. So they're contaminated or colonising the wound, but at this point they may not be causing infection. When they're critically colonised bacteria, the bacterial burden on the wound is increasing, and there's also potentially that presence of biofilm. So biofilm is when the bacteria become enclosed in a matrix, and this then means that they're more resilient to potentially those neutrophils and our own human bodies from trying to get rid of that infection. So the burden will initiate the immune response locally whenever there's critically colonised, but not systemically, and healing is delayed at this point. So this is what's going to cause the wound to become more chronic. When a wound is infected, so when it's come from that critically colonised to an infected state, the bacteria is in the form of biofilm. So this is present on the wound surface. And they're multiplying at a rate that our body cannot get rid of this infection. So within the biofilm state, bacteria are more resilient to a lot of antimicrobial properties, and a lot of topical things that are present within, or that we use within our clinical environment, will not work on these biofilms. So we may need to either take a swab to see what is the infecting organism, and get an appropriate antibiotic. So at this point, the wound may increase in size and present with those signs of infection. But at this point, it might be too late in terms of it's progressed from a localized infection to a systemic infection, and potentially osteomyelitis, cellulitis and sepsis. So it's important that we act early. We can take swabs in a clinical environment when we think a wound is infected. However, swabs can quite often pick up a lot of the surrounding bacteria and the commensal bacteria. So it's important that we potentially look at a tissue biopsy. If there's osteomyelitis present, if there's exposure of bone, then you might want to take a bone biopsy to see what is the bacteria that's causing the damage. So just to look more at biofilm, this is a concept that has come to light in more recent years, and it's present on the surface of the wound. It's believed to be a community of microorganisms attached to the surface, and they're surrounded by a dense extracellular matrix. So the bacteria are protecting each other, and they have different properties when they are acting in conjunction with one another, as opposed to their alone state. So the extracellular matrix has been reported to act as a physical barrier to penetration of both biological and pharmaceutical antimicrobials, and this is a key, and this is often why the wounds appear to be arrested. And although there mightn't be enough evidence currently for debridement, it would suggest that if we can debride a wound and remove some of that biofilm, that then we can potentially remove the potential risk of infection. So how do we treat infections? Obviously we treat with antibiotics when we deem an infection to be present. So it's very important that if we think of the antimicrobial stewardship, that we're using the right antibiotics at the right time. So if we potentially give a broad spectrum antibiotic, that when a wound is infected with, for example, a Pseudomonas, and a different antibiotic is required, we're potentially increasing the risk of antimicrobial resistance. So it's important to get either a good swab, or without touching the surrounding area. You might want to look at the exudate that's present on a wound and send it to the labs to see what potential organisms are within the exudate. The gold standard is tissue biopsy. Now, if you think of tissue biopsy, it can be a bit, there can be contraindications with this, because potentially what you're doing with the tissue biopsy is you're taking the wound, you're leaving the wound in that chronic stage, and you're potentially detrimenting the wound bed. However, if we can get a tissue biopsy, it is the best to identify what bacteria are present within the wound bed, and therefore target with the appropriate antibiotic. It's also looking at antibiotics. Do we need an intravenous antibiotic, or will oral be okay? And that will be detected by the results from our tissue biopsy. And again, is there biofilm present, which we have discussed. And although this can't be seen, and this can only be seen microscopically, but we can, if there's a film on top of the wound that can be removed, then it's important to do so. Do we cleanse a wound? So the question now is, do we use saline or not, and what does the evidence suggest? So if I've added a Cochrane review here for water for cleansing, and it's an interesting read in terms of, well, can we use water, and why do we use saline? To debride or not to debride, what does the evidence suggest? So within the debridement consensus document, and indeed within our sign and NICE guidelines, there's not enough evidence for debridement. We know at a clinical level that this might work. However, more evidence. We need more randomly controlled trials and more research to actually get the evidence to say, well, does this work or does it not? Are we potentially causing the wound healing process to lengthen? Are we actually causing a detrimental effect, or does it remove the devitalised tissue and promote healing? So a lot of there is a lot of controversy around this, and there's not enough evidence to actually give a pivotal answer for this. Select appropriate dressings. So it's important that there's a lot of dressings out there. Maybe you've different dressings within our own clinics, but it's important that we make a careful clinical assessment of the person's wound, their clinical condition, their personal experiences of wound dressings, do they have any allergies to wound dressings, and their own preferences. At a topical level, it is important to put something antimicrobial. However, this might not prevent the wound from going into an infected state, but it could be useful. I've added the nice guidelines for dressing selection, which you may want to look at, and the key points for the evidence and what evidence is out there to suggest the best wound dressing. I've also added some key papers. We've got the Freiberg and Banks and Challenges in Treatment of Chronic Wounds, and also if you want to read a bit more on the chronicity of these wounds. There's also quite a bit on biofilm. Within on the hub site, I've also added key papers within the TALIS reading list, which you will see in the wound healing folder. Some further reading, nice guidelines, surgical site infection, prevention and treatment. So you can, I've also added a YouTube video for the coagulation cascade. So thank you for listening.